Hi, everyone. Thank you for joining this week's Global Grand Rounds. My name is Katie. I am a Global Grand Round Director, and I will be helping moderate this discussion. Today, we have our Medical Director, Dr. Pekia, on the line. Before we hand it over to him, just a friendly reminder to please mute yourself unless you are speaking. Thank you, and I'll hand it over to Dr. Pekia.
Thank you, Katie, and also the staff at Global Offsite Care, the volunteers make this possible, as well as the participation and support of attendees, projects of Global Offsite Care, as well as the largesse of donors from Rotary Sebastopol and elsewhere. So thank you very much for that. I'm Dr. Gregory Pekia, co-medical director of Global Ground Rounds, the medical education arm of Global Offsite Care. Thank you for attending today. We're honored by our guest speaker today, Dr. Vedaste Hakorimana, junior medical officer at Shira District Hospital in Rwanda. Finished his Bachelor of Medicine and Bachelor of Surgery at the University of Rwanda in 2016. He'll be speaking today on pediatric presentation of acute lymphoblastic leukemia. And we welcome you and thank you very much, Dr. Hakorimana. The floor is yours.
Thank you, Dr. Pekia and Kate. It's nice and it's a pleasure to be with you here today for that presentation. As you said, so I'm going to present the course outline is the childhood acute lymphoblastic leukemia. So we are going to pass through a little bit on the introduction on the lymphoblastic leukemia, which is acute, and the definition of leukemia and the acute lymphoblastic leukemia. And also we see a little bit on the theology, epidemiology of childhood acute lymphoblastic leukemia. And we have to pass through clinical presentation and the diagnosis with management and the complication. It's a little bit for some complications, and we see some factors of prognosis. I'm passing out, but and we have to see what is the prevention of it, but it's a little bit in a few words. Next. So as you know, leukemia, it is a type of cancer of blood or bone marrow, which is characterized by proliferation of immature white blood cells. So this is related to the bone marrow, but also with the bone. And on the acute lymphoblastic leukemia, it is a type is a malignance of B or T lymphoblastic, which is characterized by uncontrolled proliferation of abnormal or immature lymphocyte and their progenitor, which is ultimately lead to the replacement of bone marrow element and other lymphoid organs, which is resulting typical disease pattern characterized that pediatric malignancy. Especially here, they say when the lymphoblast is we start to say this is lymphoblastic leukemia when we have more than 20% of lymphoblast in bone marrow when we analyze it. So ILL or acute lymphoblastic leukemia is fourfold compared to acute myeloid leukemia. It means also it is account 80% of childhood. It is also the most prominent pediatric cancer worldwide up to now. And it is occur mainly in the ratio male is more than female and is more common in white than in black. So many Caucasian compared to the black one. And it's a clinical manifestation. It is related to those diminution of blood cells component, especially anemia and the thrombocytopenia or neutropenia. And sometimes it can have, when it is metastasis to the brain, it can, we have some manifestation of CNS or central nervous system. So next. Yeah, so for the epidemiology, as I said, it is most common malignant, the predominant pediatric malignancy. We count that 4,000 people a year of a patient which is who is underweight 18. It is diagnosed main in the US, and also it is most common in trisomy 21, those Down syndrome and the neurofibromatosis 1 and the ataxia telangiectasia. So its peak age, it is 2 to 10 years, but it can be beyond. When it is beyond, it is that poor marker of poor prognosis. So, but it is more common in a pediatric patient who is in 2 to 3 years of age. So the poor prognosis mainly is associated with under 1 year, and also the adult one can have the poor prognosis. So its survival rate is increasing greater than 85% in the last 5 years, and up to now it is shown that in developed country, the cure rate is high compared to the developing country as I'm here. But we know many through the time it will be tackled, handled in developing country. Next. So on the etiology, mainly is unknown, but some articles can talk about environmental factors such as exposure to benzene, ionizing radiation, and exposure to previous radiotherapy or chemotherapy. So when some patient receive chemotherapy for other type of cancer, maybe he will later develop that acute lymphoblastic leukemia. So some article they say that it is not familiar related, and we have certain genomic, but main one is the P53. Next. So it's a clinical presentation of acute lymphoblastic leukemia. It is related to the diminished and blood component, where the patient in the clinical history, he will show us the clinical pictures of anemia, such as weakness, dizziness, and also he has those proliferation can manifest with musculoskeletal pain, either is a joint pain or muscle pain. So other one can be present when the patient has neutropenia, where the patient can be manifested with a fever, but it's occurred due to infection. But as lymphoblastic leukemia, which is acute, can have B symptoms. It can, so fever can be due to infection, or it can be due to B symptoms where it is combined with night sweat and the weight loss. So for the thrombocytopenia, the patient can be presented with epistaxis or gingival bleeding or some markers of petechiae or easily bruising. So it can continue. Next. So On physical exam, you may find the patient with hepatomegaly and splenomegaly, especially they say 64 to 64 for hepatomegaly, and the patient with acute lymphoblastic leukemia can manifest with that acute with hepatomegaly, 60% for splenomegaly. So this is due to where there is death of those blood cells which can be occurred in the spleen. So later on it can be manifest with that hepatomegaly or splenomegaly. So easily bruising due related to the thrombocytopenia, and also it can be manifest with those petechia, and also has a joint tenderness, and it can be manifested with central and peripheral pallor, and the lymphadenopathy. They say that mainly the patient can present with lymphadenopathy for many patients. Next. There is some CNS manifestation when the patient went is metastasis, where the patient can be presented with headache in the history or lethargy, and also can be presented with no nickel rigidity and vomiting. Maybe this is related to the increase the space occupying, increase the ICP. So some patient, especially with relapsed leukemia, can be presented with testicular arrangement. This is with up to 10% is related to relapse one. So the patient can be manifest with superior vena cava syndrome, where the patient can be manifest with dysphagia or dyspnea, with swelling of neck and face, and also with upper limb swelling. Next. On the diagnosis of the patient with acute leukemia, acute lymphoblastic leukemia, so you have to think at first. You have to take good history and perform better physical exam, and you have that does clinical to have that clinical pictures of and clinical knowledge about this leukemia. So mainly is related to the laboratories. Here we see on the peripheral blood film with morphology of white blood cells, and so sometimes we need the imaging modalities. So if you suspect, but mainly if you suspect that the patient you have leukemia, you have to transfer to pediatric oncology for evaluation and diagnosis and management. And here we need the cancer center for helpers. So as I said, for testing with complete morphological, this is due to peripheral blood film. So you can take bone marrow aspiration and the biopsy, so that you can analyze if you find about above 20% of lymphoblastic. So you have to know the diagnosis is that for lymphoblastic leukemia. And also you have to, sometimes we need the immunophenotyping characterization. These help us to know the type of acute leukemia, so that we can guide the chemotherapy or the treatment which is good. So we see for genetic and the leukemic cell here. For the genetic, we can see for the Philadelphia. So also with the translocation, if there is any translocation is here when we have to see on the genetic. So on the laboratory, as I said, the complete blood count, blood cell count, which show us either this is anemia. As long as for the anemia, the type of anemia, mainly on the this acute lymphoblastic leukemia, we said that it is normocytic or macrocytic. It is macrocytic because sometimes there is a folate deficiency on that cancer. So we see on the electrolyte and the renal panel LDH level for the heart one. If a patient has respiratory symptoms, we have to do chest X-ray or CT scan to see if there is no mets to the, or to see if there is a lymphadenopathy in the lungs. So next. Also, when the patient has, they said if the patient has a abdominal tenderness, you can do CT scan, CAT scan of abdomen and the pelvic one. So again, we have to do lumbar puncture for CSF analysis if we suspect there is a CNS involvement. And this will guide us also to start chemotherapy, to start treatment, and we have to see to give the prophylaxis for the first time so that the patient can benefit to be treated with those CNS manifestation. So as I said, we have to do bone marrow, lymph node aspiration and biopsy. This is for the histopathology, and also the other one can do it. Also, we have to see for the cytochemistry, especially when where we say periodic acid shift. For the acute lymphoblastic leukemia, it is positive. And in non-specific estrus is also positive, where myeloperoxidase, as I said, it is negative. So for classification. Next. For the management of acute leukemia, acute lymphoblastic leukemia, here we can see at first, we have to, before treatment, the pre-treatment checkup, we see for the chemist, how is the electrolyte of the patient, how is the liver, renal function, and the LDH, and also uric acid. And also we have to see calcium and the phosphate level if it is normal, so that we can monitor accordingly, as we said in the complication. Also, we have to see coagulation profile, such as the prothrombin time and the fibrinogen and the PTT. And also we have to do lumbar puncture. As I said, when we see there is a lymphoblast in the CSF, we have to give the prophylactic first dose of intrathecal therapy. Because this, we have to give this intrathecal therapy as some chemotherapy for the treatment of acute lymphoblastic leukemia. And they said here it is due to blood-brain barrier. The chemotherapy cannot enter in the brain. So here we have the CNS type of where the extent of acute lymphoblastic leukemia. We have 3 types, where the type 1 is when we analyze, there is no lymphoblast in the CSF, regardless of white blood cell, which you can find in the cerebrospinal fluid. Where the type 2 is when we see less than 5 white blood cell per micro in the CSF. but there is a presence of lymphoblast. The type 3-1, it is when we have above or equal to 5 white blood cell per micro in the CSF with presence of lymphoblast. So next.
Recording in progress.
Other pre-treatment evaluation, we have to screen infection. When we have to, we are at a high level of care, so we have to screen for infection, and so that we can start the empirical treatment appropriately. So according to the germ we find as infection. Also due to the anticipation of anthracycline cardiotoxicity, we have to do cardiac evaluation with ECG. And also when we are planning to do hematopoietic stem cell transplant, we have to screen HLA or human leukocyte antigen typing. So we have to evaluate also mediastinal mass, the chest mass, to evaluate the mediastinal mass. You have to do CT scan of the chest. Next. So what we know about that is that leukemia, as every cancer, it is multidisciplinary for its management. So we have to transfer, as I said before, to transfer to pediatric cancer specialist or center where there is a favorable specialties in developed country for better follow-up. So its treatment is occur in 3 phases, but the one is remission induction phase. This therapy is made with mainly with corticosteroid such as prednisone. You can start, or with dexamethasone. With those 3, anthracycline or vincristine and the one asparaginase, those for the antimetabolite. So the second phase is intensification and consolidation therapy, which is consolidation therapy is mainly used with chemotherapy, chemotherapeutic drug. This showed that there is a good outcome if the patient is not in a bad condition, or it is shown red. So other things we have to see in the consolidation therapy, we have to use those steroid, but we have to take methotrexate and associate with those induction phase therapy which we use. Next, so the next one. Next, Kate. So the third one is maintenance therapy, where we use where the article I read on the Up-to-Date see they use 6-mercaptoprin or methotrexate once a week or once a month according to the evolution of the patient. And also you can maintain this, you can range in sometimes they say 1 to 2 years. So additional, as I said, you have to give those systemic chemotherapy, which is in the CSF, or you can use intrathecal methotrexate. This methotrexate is as you know, it is the antifolate for entire course of treatment. So next, Kate. So as I said, the treatment it will last, as according to what you read, it is 2 to 3 years, but some articles say 2 to 4 years to be completed. So patient may undergo splenectomy for boosting platelet, as the platelet can be when is allowed to be shed or died, they can enter in the spleen, so that this can help also as for immune. So, but sometimes they can use radiotherapy to reduce splenomegaly or to try to shrink it. So patient also can undergo transfusion as usual when the patient has that uh, reduce the red blood cell and they reduce the platelet. You can transfuse with pack the red blood cell and the platelet or FFP. So also in the cancer center, sometimes uh, when it is specialized, they can use the medication which is related to type of acute lymphoblastic leukemia. According if it is a CD10, it is a pre-B, they find it is a pre-B or B type, so you can or protein. So you will also treat infection accordingly, but mainly based on the culture result, hemoculture, if we do hemoculture. So as for this patient, the patient I saw here in my hospital, as the inductive effect of malnutrition, sometimes we treat him or we treated him, but they treated him before as malnutrition. But later on, I have a suggestion. Maybe that patient has the something which is malignant, so that when we transfer to cancer center, PIH partners in health in at Butaro. So next. So the complication, sometimes the patient can have the complication which is related to the cancer, the acute lymphoblastic leukemia, but other can have those complications related to the chemotherapy or radiotherapy of the patient who was on it. So the first one, which is I will say about this, which is the most life-threatening as a tumorize syndrome. When the patient is receiving chemotherapy, as you know, there is a destruction of uh, red blood cell, the DNA is destructed. So this is emergence because the patient will experience hyperuricemia. The uric acid will increase and the hyperkalemia as the cell and the intracellular component, the potassium is high. And also hyperphosphatemia, as you know, the DNA is composed with uh, high phosphate, so that when it is destroyed, the phosphate increase. When the phosphate increase, the binding capacity to calcium, it is increased, so that the patient can also experience or suffer from hypocalcemia. So the patient can be manifested. That's why before treatment, you have to check up where the baseline potassium, the baseline calcium, the baseline phosphate, so that you can know there is an increase. So other things is the renal failure, which is they said is invariable according. Maybe the patient can experience renal failure, the other one cannot. You maybe due to related to ischemia. Next. The other one, which is also emergence, like tumorize syndrome, it is leukostasis. When the stasis of leukocyte, and there is the organ where it is stuck in the vessel. So you may experience the problem, the patient can experience the problem according to the organ which is affected, where on the respiratory mainly the patient can be manifest with dyspnea, hypoxia, hypoxemia, and respiratory failure. So when you manage that patient, you have to think also maybe sometimes can experience those renal respiratory failure. Other things, it is a neurological involvement where the patient with those, if it is stuck, there is a stasis of leukocyte. The patient can have those manifest with somnolence and coma or focal neurological deficit according to the brain, part of brain which is affected. Next one. So other one, as we said before, the patient can have sepsis due to reduced neutrophils, and the patient with low thrombocytopenia can have that bleeding. Also, the patient you have manifest with seizure or encephalopathy. Due to those inactivity, maybe the patient has thrombosis and the cognitive defect. Secondary malignancy, as I said, maybe the patient can be receive that chemotherapy and the other one can raise. So other things is they said that those patient with who was on chemotherapy due to they fail to grow. So maybe there, as you know, the patient, if the patient is in a good developmental or growth chart, when you destroy bone marrow, and maybe you can destroy those progenitor cell, the cell which can help him to grow, especially for the bones. Next. So the prognosis, mainly for the patient who is pediatric and above 1 year, the prognosis is good. So you can, as I said, we can see for the prognostic risk assessment, which is the age and the white blood cell count, complete remission within four weeks. If the patient complete remission within 4 weeks, you can say the patient will have good prognosis. And also cytogenetic, when you see the translocation 12 21, this will mark the good prognosis. Differently to acute myeloid leukemia. So age, as I said, if it is less than 1, poor prognosis. If it is above, it is another, they also poor prognosis, but in range, when the patient receive chemotherapy and the early follow-up, they has a good prognosis. Also on white blood cell count, if it is above 100,000 white blood cells, the patient will have poor prognosis. Next. So we classify, we have lower risk. I tried to for the average or standard risk, where they stratify age of 1 to 9.9 years, white blood cells, which is less than 50,000. As I say, for the high risk, poor prognosis is white blood cells with much more than 50, but very high when white blood cell is more than 100,000. So at presentation, this can be showed when at the presentation. So, and also good response to initial treatment, as I said, for the remission. So also the lack of cytogenetic features. So here they recommend that the patient with, if it is better if the patient with Down syndrome, you can screen and you can do that is cytogenetic features if he has it, if there is a translocation of 12, translation of 12 or 21 said, we call it mirror. So next. So they said prevention, as you see, as we saw at first, then etiology is unknown, but we have to tackle those prevention based on the environmental risk factor, which was stated in the etiology, such as for that benzene or those radiation. So next. That is my reference, the up-to-date, some Medscape, and also see the articles on the stat peers. Also, it is a continuous medical. So next one. Yeah, thank you. Your input are welcome. So, and I think it is better as long as I tried to use my English, it is not understandable, but I think I will try to do the best. Thank you.
Thank you so much, Dr. Hakorimana. That was an incredible presentation. Right now, we'll open it up to questions. Did anyone have any questions for Dr. Hakorimana or discussion points, comments?
I do. I was just wondering, what's the most, and perhaps I missed it, so forgive me if I did. What's the most common way the patients present typically?
Sorry?
I just wanted to know what's the most common way the patients present?
The most common way of the presentation of the patient here, it's mainly related to breathing and also that weakness. And as long as the patient is start to be weak, mainly they refuse to take any food and has that weight loss. So is the main one, and the weakness, that weakness, weight loss, the loss of appetite, and that breathing. So sometimes he manifests with fever. When it is manifested with fever, it is the good one which can help us to identify it before. So, but as we are in this country, and sometime we meet with those patients who is in that in advanced stage of that acute lymphoblastic leukemia.
Wonderful talk. Thank you very much.
Thank you.
We have a question.
Thank you.
Oh.
Yeah, go ahead, Katie.
We have a question from Dr. Larry Falk. Is the incidence of acute leukemia increasing or decreasing in the US and in Africa? Can you review the prognosis data?
Sorry.
So there's a question in the chat.
Yeah, let me read it. Is the incidence of acute leukemia increasing or decreasing in the US, in Africa? So here, what I lived, I see in Africa the incidence is increasing. Also I don't know about the America, but also as long as the incidence also increasing in the US, but as long as it increases is the way also the good way of becoming treated and to give a good outcome. So on the prognostic factor, I think 85% when the patient has a low risk, in between 85 to 90 percent, there is a good outcome and the treatment. And also if it is the average also above 85%, there is a good outcome. And here, if it is a high risk, if I remember, it is in between 65 to 80%. So when the patient has a very high, I don't know the prognosis one and the prognosis factors. Oh.
Perfect. Thank you, Dr.
Hello, can you
Hakorimana.
hear me? I have a question.
Yes, go ahead, Dr. Otto.
Yes, thank you so much for your presentation. Can you hear me, people?
Yeah, I hear you.
Okay, so what is exactly the mechanism of death in these leukemic patients? Is it the is it the anemia? Is it the thrombocytopenia, or it is the metastasis into other organs? Because yeah, it's a little bit confusing how these people die. Like, so
Yeah.
what exactly causes the death in these people?
So as you know, thank you, Dr. David. I think many times the patient, if it doesn't receive any medication, as long as there is a metastasis to the brain, it is also metastasis to the brain. Can also the cause of death when it is metastasis to the brain. But if you have also vena cava syndrome, there is a compression, as you know. It can lead to respiratory failure, so you can find the patient in actual cardiorespiratory arrest. So if also the patient has that anemia, that is the anemia or infection, so everything here you have. If the patient can breathe, have thrombocytopenia, can breathe until the death. If the patient has infection and you don't treat it, the infection, the patient can fall in a septic shock and the patient can die. If the patient also has those anemia, the patient will die due to anemia, but secondary to the acute lymphoblastic leukemia. So I think everything's here, even the tumoritis syndrome as a complication of chemotherapy or radiotherapy can kill you, can kill the patient. And also that leukostasis also can kill you, but secondary to the acute lymphoblastic leukemia. Is that I have what I have? Thank you. Dr. Pekia?
Katie, I have a comment and a question. That's okay.
Yes, of course, Dr. Becky.
Yeah, sorry about the drop off. Lost my connection there for a bit. Dr. Hakorimana, thank you so much for the excellent presentation and review. I have a logistical question. In your country, if a patient is diagnosed in a remote area as having this disease or condition, and they're unable to access your hospital or a pediatric oncology center, are there examples of how telemedicine technology is used to bridge that gap and bring the patient together with their expert resources, facilities, and that can initiate treatment for this patient?
Sorry. You repeat the question.
Again, our teleconsultation tools used in Rwanda to facilitate treatment, or is it still required to have the patient travel remotely and obtain their care with a pediatric oncologist, pediatric hematologist for this type of disease?
Yeah, thank you. So sometimes we have, well, as I said, in Rwanda we have that center is partners in health, or which is we call it is a cancer center, which is with Paul Farmer. Dr. Paul Farmer is now a professor. So it is good we have a pediatric oncologist here in Rwanda, so that so when the patient is suspected or diagnosed with acute leukemia, lymphoblastic leukemia, we have to transfer to Butaro, those partners in health, the cancer center, so that the patient can start the chemotherapy or radiotherapy. Except when that center found you cannot survive even after chemotherapy.
Thank you. I appreciate that. And any other questions for Dr. Hakorimana? While we're waiting, I want to bring attention to, unless it happened while I was off, the Global Offsite Care partner in Haiti, Dr. Joey Prosper, and the GoFundMe opportunity that's in the chat to support his team in Haiti. He's driven down to the Southwest, the earthquake zone, to render care. And thank you, Katie, for posting that for those who have the interest and capability to go ahead and support his efforts to help the people there in Southwest Haiti.
I just shared the GoFundMe in the chat so everyone could see it. It was started by one of our volunteers, Trina Barua, who is a telemedicine engagement liaison for Global Offsite Care.
Great. Thank you. And Katie, you want to wrap up? Again, thank you so much, Dr. Hakorimana, for this excellent presentation. And unless we have any other questions, I'll cede the remaining time to Katie to wrap things up for this week's session.
All right, not seeing any other questions. Thank you everyone for joining. This recording will be shared on our YouTube page. So if you wanted to find it later, please feel free to check it out on YouTube. Thank you, everyone. Have a good morning or evening.
Thank you.